My name is Jay Telsanya. I'm an orthopedic hand surgeon in practice in Allentown, Pennsylvania, and I'd like to present a case of trigger finger. Trigger finger is the most common cause of finger and thumb pain and causes an alteration in hand function. The condition is characterized by a painful grasp or the actual triggering or locking of a digit during flexion and extension. In advanced cases, the finger can remain blocked in a flexed or extended position, requiring the other hand to open the finger.
There, now it's locked.
Okay.
The etiology is due to a discrepancy between the flexor tendon's circumference and that of its pulley system or tunnel that the enlarged tendons have to glide through. The most important change is the hypertrophy or thickening of the A1 pulley, as seen in this schematic. Many feel this is related to the continued mechanical friction generated by movement. The goal of treatment in trigger finger is to eliminate the swelling and catching or locking, allowing full painless range of motion of the fingers or thumb. Most patients do not require surgery. In fact, I'll present some data to support night splinting as well as steroid injections can be very efficacious in treating trigger finger. This is an example of a trigger splint which should be purchased over the counter or on the internet and are typically worn at nighttime to prevent full composite flexion of the digit. Studies have been supportive of their use, and I typically reserve them for those patients who are concerned about getting a steroid injection or cannot have steroid. Steroid injections have proven to be very effective in most cases. I tell my patients approximately half of all patients with a trigger less than 6 months will get better with one shot. Of those half that don't, another 25% will get better with a second shot. I will then recommend surgery if they fail the second shot, but am not against trying a third and final injection. This is a case of a 45-year-old laborer who had failed conservative treatment of his right long trigger. He was locking on a regular basis many times a day and had to manually unlock it with his other hand. He had had relief from the first injection for approximately 6 months and only 3 months with a second injection. Surgery for trigger finger is an outpatient procedure typically done with local anesthesia. However, some patients do prefer a mild sedative. The goal of surgery is to release the A1 pulley that is constricting the flexor tendons from gliding. Normally, this is less than a 5-minute procedure. After local anesthesia is achieved and the arm is exsanguinated, the tourniquet is elevated and a small 1 to 1.5 centimeter incision is made over the level of the A1 pulley. Blunt dissection is then performed down through the subcutaneous tissue and fascia to expose
I'll take a skinny cent.
the thickened A1 pulley. Blunt retractors are placed to protect the neurovascular bundles.
Okay, take a knife.
A longitudinal incision is then made into the A1 pulley. Next, tenotomy scissors are used to complete the release out to the A2 pulley. Here you can see the thickened pulley has been released with the exposed flexor tendons. Passive motion is checked to ensure good gliding.
Good.
1 to 2 sutures are placed to close the skin and they'll be removed in 8 to 10 days.
Good.
Try to make it lock.
The patient is asked to actively flex the
And
finger
straighten.
and extend the finger to ensure that there's been
Excellent.
complete release of
Good.
the pulley
Make it
and the
feel-
locking is
open,
resolved.
close.
This is in the recovery
Open,
room
close.
post-surgery.